So, good evening, everybody. We are live now. I'll hand it over to Dr. Shrikant for further proceedings. Over to you, Shrikant.
Oh, thank you. Thanks, Ashok. Good evening, everybody in India, and good morning to everybody in the UK, and for other people joining from different parts of the world. I welcome all of you, dear doctors and friends, to this third Meet the Masters program from my center, Southeast Specialty Orthopedic Center. Today we truly have Masters of Orthopedic Surgery with us here, Professor Alistair Hart from London, and Mr. Everett J. Smith from Bristol, and Mr. Acharya will be joining soon. He's got a trauma list he's doing. He'll be joining us soon. And we've got a guest speaker today, Mr. Manish Shah from Ahmedabad. Welcome to you, sir. As an introduction, I would like to say that I should thank all the faculties who have spared their valuable time to educate us. I thank all the sponsors who are standing shoulder to shoulder with my center in these difficult times of COVID. A special thanks to Dr. Ashok Shan for bringing this worldwide through OrthoTV. And I should not forget thanking David Penford from Clockwood Medical UK for bringing this program live into the UK audience. And last but not the least, I thank all the delegates for being part of this unique, thought-provoking webinar. So as a introduction to the agenda for today, Professor Hart from London will kickstart with his talk on 3D printing in orthopedics, models, guides, implants, and this will be followed by a question and answer. And after that, Mr. Everett J. Smith will talk about 20 years of orthopedic advances in 20 minutes, a designer surgeon's legacy to junior surgeons world over. And then there is a special talk section termed, I am the robot. Is it worth investing millions of dollars or pounds on robots in a pandemic? Search for a cheaper alternative. And Dr. Shah from Ahmedabad is going to talk about 3D augmented orthoplasty, the gateway to precision and planning. So this will be followed by Dr. Acharya. If he's finished with his pelvic list, he will start off. Otherwise, I'll go before him. Dr. Acharya will be talking about a futuristic concept, the soft tissue algorithm to achieve a forgotten knee in total knee arthroplasty in 2020. And finally, I'll be finishing off with a talk on infected revisions. Where are we in 2020, the Indian experience? So without wasting much time, I will just introduce Professor Hart. Professor Hart is the chair of orthopedics at University College London. And Professor Hart is a part of the medical device regulation panel of the European Commission. He's been appointed in 2020. Many congratulations to him. He did his primary medical qualification from Cambridge, then in Guy's and St. Thomas, and Royal National Orthopaedic Hospital rotation. He has published more than 200 papers, with 100 papers as the first author, including in the prestigious Journal of Nature. These papers have had more than 4,000 citations and a very high index factor of 38. He's been the principal investigator on 26 grant awards since 2006, with a total funding of over £7 million. BBC has nicknamed as the hospital hip detective. His work on the effect of running on the knees was published by the New York Times, the Times, and the Telegraph. His work on the implants has been disseminated by The Guardian and BBC Radio 4. It was an absolute pleasure for me to meet Professor Hart last year at London Implant Retrieval Center and the Stanmore Hospital. And Mr. John Skinner is on the left-hand side, president of BOA. So without wasting much time, I will hand you over to the hospital hip detective, who's going to enlighten us about 3D printing in orthopedics. Over to you, Professor Hart.
Hi, Srinath and everybody. Good evening and good morning. I need to check that you can see my screen.
Yeah. Ashok, could you stop share my screen? Is it possible for you? Yeah, I can do it, yeah. I've stopped. Prof, you can go ahead. Thank you.
So I'm going to go ahead with sharing my screen. And you should see 3D printing in orthopedics.
Yes, 3D printing in orthopedics. There we are.
Great. Thank you. Yeah, it's always strange doing digital presentations with minimal feedback. So I do need that feedback that you're actually looking at what I'm looking at.
Yeah.
I'm from UCL, which is the Europe's largest university, and the Royal National Orthopaedic Hospital in Stanmore, which is the UK's largest orthopaedic hospital. And I'm going to share with you my experience on 3D printing in orthopedics. This work has been partly funded through my institution from these sources. My experience as a revision and primary hip surgeon of 3D printed implants and models is threefold. Firstly, I use anatomical models of my patients to explain to them and others and plan my surgery. Secondly, I use 3D printed guides to deliver my plan at surgery. And lastly, I use 3D printed implants that's off the shelf, as well as custom made, patient specific. Here we are in our multidisciplinary team meeting at the Royal National Orthopaedic Hospital, and we're discussing a case using imaging and also using a printed model of the patient's pelvis. We find this particularly useful. And you might notice it even gets the rest of the panel off using their phones and texting others so they can concentrate on the business at hand.
The art hip replacement for a 45-year-old man.
This is using a 3D printed guide for a femoral neck cut. So patient-specific guide.
Nicely fitting guide. That is very, very nice. We're going to use ceramic on ceramic bearings, but more importantly, we're going to position them precisely using jigs made for him. So that's a model of the acetabulum.
So that was the femur.
We've got a guide.
And then this is how to position the socket.
And it points.
And that tells me the vector to position the socket in that patient's pelvis. Articles on 3D printing for guiding hip replacements or patient-specific instrumentation are actually very few. They're mainly on knees, mainly for primary knees, and some have been done for hips. None have been done for complex primary hips or revision hips. These are some of the controversies being debated for all implant positioning technologies, including 3D printed patient-specific instrumentation. So operation time, radiological results, inventory, and then eventual patient function. They're all important. We've done a few published studies, and I'll take you through a couple of them. So in this one, a prospective study, primary hip replacement, what is the effect of 3D surgical planning using CT and 3D printed guides on hip replacement inventory? So this is a normal inventory for one hip replacement. About 100 components needed, different sizes of stem, cup, liner, head. We wanted to see the accuracy of our planned versus achieved sizing and the impact that had on the inventory. 100% of 45 cases were within one size of both the stem and the cup, and approximately 90% were exactly the same size. And here you see in black are the numbers of components of each type of a standard full inventory, and then in gray, using CT planning and PSI guides, what we can reduce that to. So we managed to reduce the inventory by 60%. This saves cost, this saves time, and also this increases patient safety. There were no complications, so no femoral fractures. We didn't oversize the implant. No errors attributed to a missing implant from the inventory. These are some of the post-operative images. These are actually EOS images, so standing, three-dimensional functional imaging. And we think that this is a particularly useful use of 3D CT planning and 3D printed guides to reduce inventory and improve patient safety. Secondly, what is the three-dimensional planned versus achieved position of the femoral stem? These are uncemented femoral stems using CT and patient-specific guides of the femur. Well, this paper was important. It was published earlier this year. It's important for a couple of issues, one of which is the methods. So on your left, we take the 3D in the middle, and we basically measure the difference between the two on your right. We're able to measure all angles, all degrees of freedom, all translations. What do we find? Well, varus valgus stem position basically within 1.5 degrees, and anterior posterior position less than 2 degrees. So really very accurate. But version discrepancy was much greater, sometimes up to 8 degrees between the planned and achieved. Now, the reason for this is basically uncemented stems are dictated in their position by the anatomy of the femur. Since this study was done and there were no dislocations, but it did not make me feel good that the planned version was not achieved by up to 8 degrees. So since this study was done, I've converted to using cemented stems for all. Moving on to large acetabular defects. So I get sent quite a few of these. They're challenging. Scar tissue, multiple previous operations, a dead bone, bone that's likely to break, bleeding due to the surgical exposure, a bulky implant, quite difficult to actually fit. The implant is made specifically for the patient, and so there's only one orientation in which it can be implanted onto the bone. Preparation of the bone is also required, but it's almost freehand. It's almost impossible to see exactly what's going on, and it's quite a long, deep, dark hole. These are some of the example cases. You can see how important the 3D model might be in practicing what to do before you attempt these cases. And this video takes you through one of them. I would like to play all of it if we can. It's about 40 seconds. So the models are really useful for helping with the surgical exposure and appreciating the size of the defect. Figuring out where you are. And understanding whether the planned implant really will fit. It does help with the bone preparation, which, as I mentioned, is almost freehand. We do have patient-specific guides, but it's basically free-handed. And then it actually checking whether the implant is down and fitted properly. It's worthwhile mentioning that this question exists. It's topical, it's hotly debated, and I think we're going to hear quite a lot more about this because custom implants are expensive. They're expensive to design, plan, and also to deliver. So at the RNOH, we're commonly having meetings on whether we really need to do a custom and can we use off-the-shelf implants instead. When I say off-the-shelf, I mean conventional implants, but now, of course, we're receiving 3D printed off-the-shelf implants, which give us even more options. And maybe there's a halfway house here between the off-the-shelf 3D printed implants and custom-made 3D printed implants. I started using these implants about 5 years ago, and we published a study earlier this year which looked at the CT post-operative results and compared them with the plan versus achieved. So that's this paper. And what we found was, looking at all degrees of freedom, that all of the components were within 10 degrees of the planned center of rotation in all three planes. Now, we had cases where we brought them down, like in this case, approximately 5.5 centimeters. So to achieve the planned center of rotation with such a large acute lengthening wasn't easy, and I think to do that without custom implants is very difficult. In terms of angle position, about 2/3 were positioned within 5 degrees of the planned cup inclination and version. And really that's a measure of the fit, because they can only be fitted in one place. Yeah, we have had complications, haven't had to remove any, but have had a periprosthetic fracture. I'm very hopeful for this technology in challenging defects. In fact, now for the kind of defects that I've shown you, I can't imagine going back to custom triflanges, to off-the-shelf implants for the type of implants that I showed you. There are ways to improve, and this is something that you might think of if you're attempting this. So can you do this in one go? So can you revise a hip using a 3D printed custom-made implant using the CT scan of the patient with the implant? In other words, does the metal artifact get in the way? And does the bone removed during removal of the implant also change the bone sufficiently that you would design the implant differently? So those are the two questions: poor visualization due to metal artifact and bone removal during revision surgery. Well, we approach this using these cases of discontinuity and infection, intrapelvic metalwork with infection, failed conventional off-the-shelf implants with infection. And in many of these, in all of these cases, we used, we didn't use a spacer, because the spacer, I've learned in these situations that the spacer can be more of a nuisance than a benefit. Now, that's a debatable question as to how fair that is for the patients, but having gone through it, they're certainly very pleased, but the in-between stage was awkward. This is the in-between stage. So top row is pre-implant removal and post-implant removal. So post the first stage, they had a CT scan before implant removal, and they had a CT scan after the implant was removed, and we compared the two scans. What did we find? We found that all showed differences in the scans before and after removal of the implant. So please beware that if you're designing a custom implant, when the implant is in place, then you may not be able to implant that in the position that it's designed for, because the metal artifact has meant that the implant has not been made properly to the right shape, and you've removed bone in the process. And of course, if I just go back, yeah, the future way to solve that is better metal artifact reduction from the first CT to avoid the need for a two-stage operation. So thank you for having me. Thank you for listening to this. I've taken you through the use of 3D printed applications in orthopedics in three contexts. So one, as anatomical models to explain and plan surgery. Secondly, deliver the plan. and lastly, the use of 3D printed implants themselves. Many thanks.
Thanks, Alistair, for a fantastic presentation. It was completely mind-blowing. And just last couple of questions, if that's okay. And one of the articles I was just reading, you giving an interview, and you mentioned that spending extra 2 minutes, in putting a femoral a PSI jig can improve the longevity of the hip by around 20 years. Can you kindly explain a little bit more about this, please?
Yeah, so the implant position we know is critical to performance of the implant, to how long a hip replacement lasts. In fact, there are 3 factors that determine how long an implant lasts. One is surgical positioning factors. Second is implant factors, and the last are patient factors, what the patient does with them. The only one of those 3 that we can influence at surgery, of course, is the surgical implant positioning factors, how we do the surgery, and in particular, cup inclination and cup version has seen particular importance with metal, but applies to all bearing surfaces. So the point of that one-liner that you have quoted from me is better positioning will improve the life of your implant.
Thank you. Just to add on to this question, you mentioned that the future of orthopedics would be like personalized medicine, where we find out what is wrong with a particular patient and give customized solutions to him rather than just off the shelf. And you've done a lot of work on the SIP factors, which you just mentioned. How does the patient factors and the implant factors affect the longevity of the implant? What patients can do wrong to the implant?
Yeah, I think there needs to be more work done on patient factors. So, for example, at revision hip surgery, when we're often dealing with a scarred situation, a previous operation, sometimes radiotherapy, infection, osteoporosis. So these will all affect the chances of success. And the 3D printed options are basically giving us the best chance of success, even when we're faced with those difficult patient factors. More work needs to be done, for example, on bone quality. I see imaging giving us a much better map of where the best bone is, where the bone is alive or dead, so that we can achieve fixation or even screw hold in those good bits of bone.
Everett, any questions to Prof? Dr. Manish, you got anything? Everett first.
Well, Alistair and I could sit and talk about this for years. I mean, first of all, fantastic talk. There's not much that I don't disagree with it. I gave it in one line, and I can pass by that one line. I have, as you know, a great belief in these kind of designing implants rather than off-the-shelf implants. And I think you've hinted at it, but I think it's going to get cheaper. I don't think anything in the world is going to kind of stay at this ridiculous point. And on that note, you brought up that watershed. And that watershed, obviously, you'll get the economists in, and they'll give you the qualities and the costs, and they'll be able to put that variation. But there is a watershed. There is a watershed at a point where an experienced revisionist actually can look, and particularly if you've done modeling, can look at something, and based on one's own experience, you know pretty much what you can get away with. Equally, there's a point where you know you're in the poo and you can't get away with it, or you're going to struggle. So based on those kind of suggestions of your watershed, you could then apply comorbid factors, the elderly patient, the one that's not going to walk around, the one that's actually potentially going to go off and do sort of running and swimming like you. So you could bring in other different factors, and you could, in fact, set up an algorithm for a watershed in the work that you're going through, even though you've obviously putting a lot of money in it. So I think there's something that you can delve into just as you're sitting speaking to me. I'm just sitting here and I'm thinking, well, here's another paper for Alistair's group, because I would have loved to look at that, but where Louis Solomon said, if you're in Bristol and you've got lemons, you can only drink lemonade. You're in UCL and you've got a lot of scenarios at your disposal. So that's the one thing, that's food for thought, and hold on to that, because I'm sure you'll want to respond. The other that's very surprising is that you dismiss the broadsheet of all the different designs of cementless total implants on the basis of 8 degrees. I mean, I'm fascinated. I am fascinated. When you go to the toilet, are you very accurate at aiming?
Great questions as ever, and terribly practical and useful ways of drilling down into what surgeons are worried about. So yeah, I mean, you're right. You can't throw the baby out with the bathwater. Hopefully, my comments get you thinking. I know that for quite a few years that when I would implant an uncemented stem, and I would look down the long axis of the femur, and I would look at that and think, that's not as anteverted as I would like. That really bugged me. I've not got a dislocation rate that's at all significant. I'm not really worried about dislocation. But the work I've done on in fact, version and metal hip replacements does tell me that version is important for wear of the implant.
Absolutely.
And it just doesn't feel good that when we're aiming for 20 degrees of version of the stem, the femur for a well-sized uncemented implant doesn't let me put it there. Now, yes, where should it be? Well, whilst we're waiting to be told where it really should be, and it may be patient specific, I'm aiming to put my stems in with 20 degrees of anteversion, and the design I was using didn't allow me to do that. Now, before I've used 3 main designs of uncemented implant. I've used the Furlong for 6 years. I used the Karai for 7 years, and I used the Medacta for about 4 years. So I don't change very often. So before just changing to another one, I know how to sort the problem out, and that is using cement. I'd like to go a step further and actually have a patient-specific guide that sets the version for me of the femur. And that will not be possible with an uncemented implant. So it will be possible with a cemented implant. So I think I'm going to stick with that. Further on from that, we're now doing a lot of work on what actually is the version of the femur, and how can we really predict which stem will end up in which version? And then actually maybe we'll be able to say, well, actually, if I did continue using the Furlong, the Karai, or the Medacta, in this patient, will I get my 20 degrees of version? And then who knows, maybe I might use the odd cemented stem, but I've taught you through
No, that's fine. I mean, I thought that's what you were going to come off. You can control the cement very well then?
Well, I'm hoping that the patient-specific implant guide will actually set the stem within the cement mantle in exactly 20 degrees of antiversion. In the meantime, I'm using visual assessment, like we all do, to give me the version. But when I was using uncemented implants, I didn't have any choice. I tried to lateralize and try to antivert as much as I could, but having done the CT study, they didn't all end up in the position that I wanted.
No, that's fine. And then obviously the MRI scan, you know, there are MRI scans and MRI scans. So you can take your MARS to the, or your CT scan to the best place, and you can sort of change certain things, can't you? I mean, you know, some MRI scans are poor. So in other words, the preoperative scanning can be optimized fantastically. So
I think there is a bit of a barrier to entry into this type of work, and the first barrier is can you get the scans done properly? What should the protocols be? And then taking the data into 3D analysis software, can you then use the data? At the moment, this is not very accessible to most.
Sure. Which is my comparator between Bristol and you, because I mean, I would use them 3 or 4 times a year on the very bad cases.
I mean, we do have some really fantastic imaging scientists at UCL for sure.
Thanks, Alistair.
That was a stimulating discussion. Thank you. I think the note question in the chat box. So Dr. Manish, you have any questions? You need to unmute if you need to ask.
It was really an enlightening talk, and no questions as of now. Thank you.
So thank you. So I think we'll move on to the next part. Prof, if you can unshare your slide, I will put on share my slide. Thank you. So thanks, Prof. Thank you for that. Our next speaker is my mentor, Mr. Everett J. Smith. And, you know, it is my pleasure to introduce him this evening. Mr. Smith is a consultant orthopedic surgeon at Spire, Nuffield and the Lister Hospital, London. He was a former UK representative of the European Hip Society. He is the designer surgeon of Zimmer Biomet Exceed Cup, particularly the face-changing liner. He is the program director of the fantastic Bristol Hip Arthroplasty course. And he is a fellow of legendary professors, Professor Bill Harris and Professor Wagner, which every orthopedic surgeon in the world knows. He is a member of the ODEP, the Orthopedic Device Evaluation Panel, Beyond Compliance in the UK, and also coordinator of the National Joint Registry from 2003 to the present time. He is also advisor to the British Hip Society on negligence and concerns of poorly performing implants. So he comes with us with a lot of legal background, and you know, he's going to tell us how to put the cup perfectly in all situations. He is also editor-in-chief of a fantastic reconstructive review journal and editor of the Hip International and the British JBJS. This is Everett, you know, doing the first spare approach in India a couple of years ago at AIMS with me, and you know, and on the right-hand side is Everett inaugurating our first Meet the Masters course in Bangalore. So it is a pleasure to introduce Dr. Everett, and I hand over the podium to Dr. Everett. Thank you. I'll just stop sharing. Ashok, could you stop me and allow Everett to sharing?
Can you hear me now?
Yeah, I can hear now. Did my introduction go through or?
No, that's fine.
Okay,
Thanks,
yeah.
everybody. Alistair Hart invited me to the sort of Zoom Seddon meeting. And in a moment of madness, he asked me to encapsulate 20 years of my thought processes. And I think, as he said this morning earlier before we went live, I've got about 5 talks that I could give on different aspects of this. But he and I have very similar passions in terms of what we do live and like and thrive on. And he is a true intellectual and I am a pseudo-intellectual. So that's probably the difference between the two of us. So I'm going to try and encapsulate 20 years of my thought process. I've adjusted the talk a little bit because of Shree's going to do something on infection. So I'll just take you through these sequences and I'll probably slow down at the areas that I've been requested to divulge and show my Indian friends and colleagues and all of those over the world. So this is my disclosure. I'm going to talk on the following: the internet, arthritis and hip arthroplasty, hip approaches, LLD and dislocation, robotics, obesity, bearings, acetabular cup position, revision hip surgery, design and development. The internet has changed the way the world works, and as a result, there's been a fundamental change in the way individuals manage their healthcare. Risk aversion is a factor in every aspect of daily life. We are a society where the use, creation, distribution, and manipulation of information has significant economic, political, and cultural impact. The global internet has risen from around 400 million in 2000 to 4 billion in 2020. The search engine and social media is now providing key channels for communication, relevant health education, and care information, amongst, of course, other things. The internet has increased use of healthcare delivery online, and you can see the number of places you can go to have a look at your health problems. The internet has impacted on the doctor's trust, patient's trust of their doctors, and the perceived quality of care and patient compliance. And there's no doubt that the traditional patient-doctor model has been altered forever because of the internet. And it has contributed to the deprofessionalization of the medical fraternity. Arthritis and hip arthroplasty. We all want maximum quality benefit, and we've been hearing how Alistair's doing this today. And we certainly want a hip for life if we can aim for that. This iconic paper from Kurtz projects the primary and revision hip and knee arthroplasty in the States from 2005 to 2030. And we're sort of somewhere on the upward curve, but you can see what is happening and potentially going to happen in the future. What has changed? The early THAs were really modifications of hemiarthroplasties for fractured neck or femur. And then along came the Charnley hip replacement. Now, of course, I could challenge Professor Hart and say, can we really beat this operation where we had no aids, no supports? And in Cape Town, we did take off the greater trochanter, put in a glue hip, and get a long-term outcome or survival. There are basically 3 hip approaches that are standard to the hip replacement: anterior, posterior, and lateral. The Hoyter anterior approach in 1870 sort of got lost in the mist. And the anterior approach almost disappeared, but for the work of Thierry Joudet and Christophe Kelly and others. I went to Wrightington before going on for my fellowships and always struggled with the closure of the greater trochanter until I was taught to do it by David Murphy. There are very few people doing this approach in 2020. There has been a surge in minimal invasive surgery over the past 20 years, both in the anterior approach and the variations of the posterior approach to the hip. It's given us less surgical dissection, reduced blood loss, diminished postoperative pain, so we hope, shorter hospital stay, potentially a quicker return to function, and there's been a revival of the anterior approach. There's an evolution of the posterior approaches through those that you can see, and as Shree mentioned, I do a variation of a direct superior spare approach when I'm pretty much on my own in the private sector. Minimal invasive surgery is performed for most surgical approaches now, and MIS for THA in the development stages showed that the reviews and outcome were mixed or poor. But by 2017, MIS for THAs was extensively used, and different access pathways have evolved, showing a variation in the results. These problems are there forever, and we'll be fraught with them till the day we die. These are always the surgeon's faults, and leg length discrepancy, particularly in the USA, is a common cause of complaint and the reason for litigation. With increased dislocation risks, along came the mobility sockets from robotics. The first assisted THA was performed in 1992. It does provide accurate and reproducible component positioning and balancing soft tissue. The defined ideal cup placement is significantly higher when you use a robot. But there are problems. There's a learning curve, increased surgical time. There's no real difference between functional outcome scores, LLD, there's really no difference. And the revision rates, of course, unclear. There are certainly problems such as dislocation, infection, nerve palsy, DVT, thigh pain, and heterotrophic ossification, all of which are increased with the use of robotics. The Trendelenburg positive rate was significantly higher in a meta-analysis with robotic-assisted operations compared with conventional THA. Obesity. Obesity is now fourth on the risk of deaths in the world, as you can see from this beautiful slide. Obesity negatively affects the survival of lower limb replacements. The BMI of greater than 25, which has increased from 23 to 34% in the last 20 years, is a problem. And this will give us a massive healthcare cost burden. It's estimated that around 50% of Americans will be obese by 2030. The increase in morbid obesity has accentuated mobility-related disabilities, and obesity is linked to many comorbid factors as identified by Holgram in 2014. The increasing BMI and prevalence of knee OA indicates that total knee replacements will far outnumber total hip replacements in the future. Well, materials matter. We've heard about Alistair with position and implants, and he ducked the one of materials or bearing surfaces, but I know he understands this. So polyethylene has really changed, and it's accelerated through different phases, and we now have excellent polyethylene, which is getting very close to the wear profile of ceramics. In 2013, the Australian Registry identified the reduced risk revision rate with crosslink polyethylene. Ceramics is a beautiful material, and it has shifted from the development of through Forte to Delta, which reduces stripe wear, and Delta ceramic is most definitely a wonderful material for hips. It is inert and low wear bearing. Acetabular cup position. Well, we heard a little bit of this from Alistair today, and these are the problems. We have problems of impingement, dislocation, increased bearing wear, problems with metal ion levels when you increase the inclination angle of the acetabulum above 55 degrees. You have associated osteolysis, component loosening and migration. And of course, in the work that I do, because I see many young patients, it's difficult to position a cup well in CDH and in revision hip surgery, in particular where there's bone stock loss. And there's a significant risk factor in posterior pelvic tilt. So my sentence to you is that the final cup orientation must consider cup containment, impingement with implant, bone and soft tissue, preoperative skeletal and soft tissue abnormalities to achieve the optimal compromise for each patient. And I believe that's what Alistair is going for. Levennick's safe zone. My personal opinion was this was an awful paper. The inclination angle of around 40 degrees and antiversion of 15 degrees was the safe zone. The cup in the Levennick safe zone does not actually protect against posterior dislocation of the hips. And I suggest that the safe zone should be converted into what is described as the optimal cup access range. This acetabulum works around, as we all know, 3 orthogonal axes. The variability of cup orientation is affected by pelvic orientation at the impaction of the cup. And MIS, even though there are very different papers in the literature, basically, to me, has shown around a six-fold increase in cup malposition from a more constrained working place and reduced visualization. Well, we all know about the TUL, and we're thankful to David Beveland and his co-workers in Belfast for bringing us this to our notice. There are positions where you can use the TUL to advise you on where you should place your cup. And the papers identified that a cup inclination angle is about 13 degrees higher where you think you are in the operating room, and you should always think to lower your inclination angle with your trial and then with your definitive cup when you're inserting it in the operating theatre. Impingement is a problem with hip replacement, and that is also associated with edge loading and wear in hard-on bearing and obviously soft bearing cups. The significance of impingement is that you get component damage and you get subclinical subluxation, which is not talked about. And I discuss and debate often with my colleagues about habitual subclinical subluxation, which occurs in total hip replacements. So the posture, cup placement at surgery does not translate to the cup position when the patient stands or sits. The patient with an inclination angle of greater than 50 degrees and an anteversion of greater than 25 degrees in the cup, as well as a hypermobile pelvis, are at risk of impingement. And the cup should be positioned in less inclination and anteversion in patients with a hypermobile pelvis. And I owe it to a good colleague and friend, Lezesnik, Jean-Yves, who basically brought this to my notice many years ago. And this is a beautiful drawing showing the lordosis angle linked to the sacral slope. He loves the pelvic incidence, which I hate, but he links it to the cup, and he can show you where you're actually positioning your implants. And he uses EOS or EOS. Right, cup inclination and anteversion is synergistic with the pelvic tilt, and that's the take-home message. The effect of pelvic tilt on cup orientation is predicted by the stiffness of the pelvis. And it's very difficult to bring all of this together if you really haven't examined the patient properly, which you should, and then bring it into theatre. So you have to keep it simple. And if you've got a stiff back, you're out of the problems. If you've got a hypermobile back, you have to think very carefully about where you position your cup. So I suggest we adjust the cup to the optimum cup axis range. And this has changed from the perspective of targeting the so-called safe zone, which every sort of unread orthopedic surgeon suggests we should do. And these are great drawings showing the differences between the stiff back position from standing to sitting, to a normal patient from standing to sitting, and a hypermobile back from standing to sitting. And you can see even in the axial sections how the cup and the head differs. The capital hip system was a failed system, and there was a hazard gnosis on this stem. And if the data had been collected and analyzed, the disaster would have been avoided. Some 4 years later, the NJR was established, as was ODEP, to implement guidelines on hip replacements. And then in 2015, I was invited to join Beyond Compliance, which evaluates new hip devices into the market in the UK. The second wave of metal-on-metal hip replacements or resurfacings came in the late 1990s. The starter was the Birmingham hip resurfacing, which had an arc of cover of 160 degrees. We all knew why we were told to resurface: better survivorship, better function, easier revision options. The BHR and a few other RA brands had a good medium-term results, but many other resurfacing designs came to market with the basis of equivalent with minor differences. And by 2005, we already knew that the revision rate was higher than conventional total hip replacements. In 2007, the Australian registry identified that the ASR had twice the risk of revisions as compared with other resurfacings. And before 2000 to 2003, ARMD was not one of the important indications for revision hip surgery, which of course it became during the era of metal-on-metal bearings. ASR is an equivalent device with minor design changes. And this slide shows these subtle changes that were put into the design. But the most important one was the reduced arc of cover to around 150 degrees. The ASR device as we know, had a failure, 26% at 10 years, and the ASR large head metal on metal bearing total hip replacement had a 44% failure at 10 years. Large head metal on metal bearings brought in metallic wear and corrosion with the associated pseudotumors around the joint as a result of this disparate spraying out of metal debris. So what do we have? We have the normal wear in a cup and over the dome of the head or the polar surface of the head, which is contained. If the wear becomes rim wearing or edge loading, the rim breakout wear is adverse. And these adverse wears are shown as large stripes within the surface as compared with the normal scratches that you would see in a normal wear contained cup. This is a picture of the different synovial fluids and a Mars scan of ARMDs. And because of the metal and metal bearing problems, there was evidence of change of bearing surfaces in the NJR, as shown on the slide from 2007 through to 2012. There was also a change in fixation, where there was an increase in the use of hybrid hip replacements from 2009 to 2018, and this is continuing. Large heads are now more popular, and the articular bearing surface, based on the fact that we know materials matter, has shown an increase of ceramic on polyethylene as one's favorite bearing surface. Revision hip surgery, well, the objectives are well known to us, and we grade the extent of the bone defects accordingly, and Alistair gets a picture of them so he sees them visually, and then we try and restore this bone stock loss. And the revision hip burden still remains around 15% of total hip activity worldwide. And as a trainee in Cape Town, I certainly was involved in numerous Girdleston's procedures on a regular basis because revisions were not able to be done by our bosses in those days. And the technical advances that have occurred in hip replacements have almost made this operation extinct. We've heard what Alistair said, and bone grafting is important. And I don't particularly like the custom flange implant, but you can obviously utilize this with bone grafting. The most important bone grafting to come out of Holland and this country is the morselized impaction grafting, which is used to fill bone defects. There was a rapid migration of this technique from 1993 onwards. Unfortunately, it is technique dependent. Porous metal has made a huge difference to our life and has demonstrated excellent long-term survival. These are pictures of the use of porous metals in some of my operations in Bristol. We've heard a beautiful talk about 3D printing and specific designs and utilizing them for uncontained defects, and we've discussed this in question time as well. Modular systems have made a wonderful difference to aid us in soft tissue attachments plus ligamentous attachment approaches as well, and enabled us to deal with fractures of the femur and go long and strong even beyond the knee. Well, Sri asked me to talk a little bit on design and development. I seem to have a twizzled mind that goes elsewhere, and the times have changed and the times are a-changing. The orthopedic companies now prefer a gaggle of orthopods with input on one product. And these are usually high-profile surgeons. The companies tend to skirt around patents, and they have an integration of ideas to adjust original products that they fancy. I think one should think outside the box, and you should use your imagination. You should always try and be creative and think what is missing. You must think, if you think in these manners, you must think about shapes and design and what is needed. If you are skilled or very good at biology, you can use your thought processes and enthusiasm in genetics, microbiology, immunology, and histopathology. If you're mathematically orientated, you can go down the route of changing radiology using physics and engineering. Don't be embarrassed by your failures. You need a lateral thought process. You should identify your area of skills, and we're all different. And you must think what could or would change and what can make a difference. I suggest, as I learned in my youthful years, that you should register and patent your ideas. You should design and develop prototypes before you expose it to the world. And if at all possible, you should take it to a small dynamic growing company or start up a company of your own with friends. I think if you are smart, educated, and experienced, you should always try and challenge orthodoxy. You should lever the assets that you know about, address untapped needs, and harness unvalued trends. Over my 20 years, I have seen a changing world. And the first paradigm shift, I believe, has been the World Wide Web. The second paradigm shift we're in now, and that's the coronavirus pandemic. There has been a seismic change in life as we know it, and this will resonate for decades to come. We have a massive challenge in medicine due to COVID-19 infection. And I'll leave you with this quote from Einstein. We cannot solve our problems with the same thinking we used when we created them. Thank you.
That was Everett, absolutely mind-blowing. I'm speechless, you know. And I think most of the Indian orthopedic surgeons were waiting for this talk, and I just can't express the words. And I think, like Alistair said this morning, and I think you should write a book putting these thoughts, and it will be the bestseller in the world. I can bet on that. So thank you so much. Alistair, if you're there, any questions for Everett? Alistair, you need to unmute yourself.
Oh, he's got his mask on.
Okay, yeah. Can you unmute yourself, Alistair? Thanks.
He knows the talk backwards.
Any questions for Everett? Thanks.
Everett, I think that was absolutely brilliant. I mean, as you know, I've heard bits of that at the Seddon, and I could keep hearing that because so many things brought up. One of the things that's particularly interesting that I didn't pick up before was the girdlestone issue. I mean, maybe girdlestone is coming back temporarily, as I showed a little bit in my talk prior to giving people custom implants, which I thought surprised me. So 20 years ago, we were putting in metal hips. In 20 years' time, we're still going to be using metal implants?
Well, I think there's a role for them. But I think the role is in very selected patients, very carefully selected patients. And I think not casually like we did them before. Just listening to your talks and knowing what you and I love, I think if you're going to do, let's just take resurfacing arthroplasty, and we just decide there's a role for the use of resurfacing arthroplasty in selected patients. And certainly I suggest by selected surgeons and selected brands or implants. So once we've got the three things that you talked about, and we have the ability to put them in perfectly and understanding the spinal pelvic axis, I definitely think there's a role for large head metal on metal bearing total hip replacements.
Really interesting. I'm afraid
eh?
I've been sent just too many that haven't worked actually. So
no, but that's a shocker. I'm very carefully said in selected patients.
It's going to take a lot for me to overcome surgeon, implant, and patient factors.
Absolutely.
To recommend.
And so have I. And you know who I kind of think of. I really think of the flanker in the rugby team who's 38 years old and nothing is going to work because he's got a low IQ. All he wants to do is play rugby and tackle and bash people up. And I can only think that the perfect surgeon putting in a perfectly positioned, perfect implant in a Saturday afternoon crazy flanker for Harlequins is the perfect operation.
Although metal debris disease is non-discriminatory, it's their immune system that we need to know about rather than which rugby team they play for, which position, and whether they're whether they've got lots of good muscle around them. I think I mean the answer for metal hips for me is the immune system, but I don't know.
Are we going to find the answer?
Well, we didn't really for metal on plastic, did we?
No.
So what we did was we reduced the dose by moving to highly cross-linked polyethylene. But who knows? I mean, the whole of molecular biology is increasing at a massive rate. So hopefully these detective stories will become solved quicker.
Interesting.
Edward, what's happening with the ceramic and ceramic resurfacing? Is it good, bad, or ugly? What's the?
I think Alistair's closer to that in London. Most certainly, he wanted to squeeze me on a tiny little area, and I stuck to my guns. But Alistair could give us an update on perhaps what's happening close to him or with one of his colleagues in London.
I mean, we are. John Skinner and I at Royal National Orthopaedic Hospital are interested in particular in newly introduced implants, and I think there is so much unknown about ceramic on ceramic hip resurfacing. Our interest in newly introduced implants is basically about solving detective stories, and I think there's a lot to solve with ceramic on ceramic resurfacing. So I would hold off thinking about that for now.
Interesting.
Dr. Manish, any questions to Edward?
That was a fantastic summary for 20 years.
Thanks, Manish.
Okay, so I think I'll move on to the next part. A message just texted me that he had a COVID patient and he had to go into theater. That's quite unfortunate. So I think what we'll do is we'll stick to original plan. We'll get Dr. Manish to talk next, and after that I will talk. And if Mes comes out of the theater, then we'll put him in the end. Save the best for the last. Can you see my slide?
I'll need to stop sharing. No. No.
Okay, so this section is titled, not provocatively, but just to elicit debate, I am the robot. Robots are not in a pandemic. Do we really need to invest so much of money on the robots at this time? This is the title of a talk of a very senior surgeon, just a month ago. And initially my thoughts were, is this an arrogant statement? Then I thought, hang on, the statement was made by a very high volume surgeon in India. He's a designer surgeon for Persona knee system as well. And he's a high volume surgeon, and he does on an average around 2,000 knee replacements a year in Delhi. And he's been doing this number consistently for the last 10 years or so. So I thought, there may be more meaning to what he's saying than what it appears. So this is one of the x-rays of a 30-year-old knee replacement surgery. You can see that on the left-hand side, it is an uncemented implant. On the right-hand side, you can see that it's a tibia all poly implant. And 33 years down the line, there is no osteolysis. The real question is, can the robot really match this? And what is the secret behind the success of these, two x-rays? The secret is good alignment, good balancing, and great fixation. So, and that seems to be the key for this particular two joints to be doing quite well. So let us look at the evidence for robotics in 2020. We know that around 2 degrees malalignment, particularly in the femoral component of the unicondylar knee replacement, occurs in around 50% of manual UKRs, and this can lead to poor outcome. Robotic basically eradicates this, and we have a 5-year published results of robotic unicondylar knee replacement, giving 97% results by Fabio Catani group. But as far as total knee replacement is concerned, there is no long-term evidence of robotics in TK at present. So at present, the non-robotic knees, they are giving around 98% 10-year survival, and they are giving around 95% 20-year survival. So the bar is already high. So can the robots really improve those 2% in 10-year survival rates? It's a big question. We know the Sharkey published his classic paper in 2014, where he said malalignment was the major cause for aseptic loosening and revision. We also know Parrott in 2010 produced another classic paper where he said that well-aligned knees had 15% revision, whereas outliers had 13% revision. So the real question is, does stability trump alignment? And I think to address these issues, I think Dr. Shah, and if Mess comes back, they will be addressing these issues. So this brings on to the concept of innovation, creativity, and lateral thinking. And Everett greatly touched on this, and it was an amazing presentation. And, Prof. Mohit Bhandari is quite well known in the orthopedics circles in the world. He's the CEO of OrthoEvidence. I sent this to Mohit. I don't know if he's watching it from Canada. Hello to him. And he's very popular in the Indian circles. And he was addressing Karnataka orthopedic surgeons around a month ago about innovation and creativity. And he said that 20% of activities in life give 80% satisfaction. And it is for us to find which are these 20% activities. And he said that a 5-year-old has got 98% creativity, but an adult has only 2% creativity, as per the paper from George Land and Co. And when it comes to performance acceleration, there's a paradox. The paradox is that the greater speed we push, less effective we become. So we have to slow down enough to reflect on what we have done and where we are going, as per Hegel et al. So this takes me back to a very fascinating 2,000-year-old, more than 2,000-year-old story from India, from Bihar. There was a young prince, in Bihar, who had everything in life. He had the girls, he had the, he had the wealth, he had whatever food he wanted, whatever drugs. He literally had everything. He experienced everything, but still he was not happy. So he said, all these things, whatever I'm experiencing in life, is only giving me temporary happiness. But he said, I want and I deserve permanent happiness in life, not temporary happiness. So he had a very strong mind. He was more of a scientist. So he renounced everything, went into forest, meditated, and after several years, he attained enlightenment and what is called nirvana. And he came to be known as Gautama the Buddha. And he told this more than 2,000 years ago, the same concept, that it is not speeding up, actually slowing up the mind, which actually gives the answers. And he said that the human mind has a tendency to either stay in the past or it stays in the future, but it never wants to stay in the present. And, that brings us to the power of now, or power of present. And Eckhart Tolle from Germany, but he lives in Canada now, he has written an amazing book, and this was my lockdown time reading, and I strongly recommend it. It was the New York Times bestseller. And he quotes Einstein. He says, thinking plays a subordinate part in the creative work of human beings. And he makes another paradoxical statement. He says, why majority of scientists are not creative is not because they don't know how to think, but because they don't know how to stop thinking. So it took 3 days for me to really understand the meaning of this. But that has sort of transformed my own life actually after that. So moving on from this science to metaphysics, I will come back to the innovation. And one such innovator is our next speaker, which is Dr. Manish Shah. Dr. Manish Ramesh Shah is a founder of the company called OrthoTV in Ahmedabad, Gujarat. He did his MS Orthopedics in 1993, and he was a consultant in Kanpur till 1995. He did a famous Kurgan Elizaro fellowship in August 1995. And he also did another trauma fellowship in Moscow in Russia under Professor Oganesian. And he's the owner of Dr. Shah Hospital, and he's a passionate believer of 3D technology in orthopedics. And like all of us here in this panel, and over to Dr. Manish Shah for a 3D augmented orthoplasty, a gateway to precision and planning. Thanks, Dr. Shah. The floor is yours. I'll just stop sharing. Yeah, thank you. You can share.
Thank you for the kind words, Sri. I think.
We can see
Is my screen visible?
Yeah, we can see you.
Okay.
Holy great.
Just a small shift in topic from hips to knees. And we all are looking for the Holy Grail. We're looking for one answer which will put an end to revisions for knee. And what are the buzzwords as in 2020? What are we looking at? We're looking at customization. We're looking at precision and accuracy. And we need to live in the post-COVID normal, wherein we need to lessen the exposure risks, decrease operative time, and be cost effective. When we talk of customization, we're talking of two things. One is custom implants, and second is custom alignment, based on a patient's individual anatomy. With the knees, we have known that 3 to 5 degrees of undercorrection from the neutral is probably the way to go. But more importantly, a recent paper from Bonin's group shows that custom implants facilitates restoration of constitutional coronal alignment. Now that is a new concept. If the implant has been customized for the patient, it helps in restoring custom alignment. The challenges today we face in terms of customization are twofold. Defining the anatomy in 3 planes precisely, and secondly, creating the custom implant. Let's take the first one, defining anatomy. What have we been doing? We've been using X-rays, but we've known that X-rays do not share the complete anatomy. We have been able to create 3D bone models based on X-rays, but all those AI algorithms effectively fetch is the closest 3D model to the X-rays from the database. They do not give you the custom view of that individual knee. Per operative inputs that we have been using for computer navigation, for handheld robotics, are error prone. There has been an excellent study way back in 2008. It was a report of 70 cases wherein they compared CT scans with intraoperative navigation measurements. And they found that CT scans probably was the way to go. Regarding making a custom implant, there are 2 ways. One is we can create a custom implant, and second is we can have an ability to choose the best fitting implant from a variety of off-the-shelf implants. It's like going to a mall wherein you have multiple brands available and then checking which is the best fit for your individual waist. Thereby, it saves time and cost. Thus, in our pursuit of perfection, in terms of customizations, what we felt was that probably pre-operative CT scan helps us define the anatomy the best. And if we can choose an off-the-shelf implant, which can mimic or come as close to a custom implant for that individual patient, that would be perfect. In terms of precision and accuracy, we are borrowing this from shoulder arthroplasty. Patient-specific 3D templating or planning has significantly improved accuracy versus the actual patient-specific instruments themselves. One study found no significant differences between 3D planning and PSI although both improved accuracy significantly. The paper goes on to say that three-dimensional preoperative planning can possibly make surgeons more cognizant of deformity, such that they make subtle changes based on their plan that actually increase surgical accuracy versus the use of the physical guide itself. Thus, on this premise, based on a pre-op CT scan, if we can have a planning precision of up to 0.5 degrees, planning performed by the surgeon, we can choose an off-the-shelf custom implant and then have a simple execution. We would have a system which would help us improve our accuracy significantly. Out of that was born Knee 3Viz. It's a CT-based 3D planning system with image-derived modular instrumentation. The CT scan center directly uploads the CT scan onto the web server. It's a raw data export. There is no processing. There is no reporting required. As the distance between the slices is close to 1 mm, the accuracy of the planning is close to 1 mm. The CT scan is processed and uploaded back on the web server with a turnaround time of less than 2 working days. The surgeon can then work remotely on any laptop with an internet connection. It allows us the flexibility to plan preoperatively without the pressures of the operating time and pressure on the theater. The advantages are that we can plot both mechanical and anatomic axis for the femur. Thereby, we are free to use conventional instrumentation or opt for the modular patient-specific instrumentation. Similarly, in the lateral, we can plot both the mechanical and the anatomic axis. Because of that, we are able to accurately define the flexion of the distal femur with respect to the mechanical axis. Thus, we can plan the flexion of the femoral component with respect to the mechanical axis very, very precisely. For the transapicondylar axis, we can plot the bony landmarks. Moreover, with a circle or a sphere around the center, we can actually see the functional axis of that condyle and see how close the anatomy comes to the physiological center of rotation for that individual condyle. With that data with us, we can then plan the surgery so that the distal cuts and the posterior cuts can be matched. Moreover, we can see what is the amount of the posterior slopes, both for the medial and the lateral proximal tibia. The overhang evaluation is very clear. Because the patella is in the natural position at the time of acquisition of the CT scan, it's very easy to see how the patella will sit on the implant. This is probably the first planning system wherein we can visualize mid-flexion instability. We can look at the curve of the implant and the curve of the native bone, and thus see whether we are ending up with a mid-flexion instability. Effectively, we have an ideal post-COVID-19 planning tool. Precise anatomic definition of the individual patient, more kinematic alignment in all three planes, compatible with work remotely, All planning is detached from the operation theater, so lessens time and surgeon exposure risk. It decreases the need of equipment and personnel in the OT. As we can see, in the coronal plane, we can actually look at the sulcus line of both the implant and the native bone. We can see where the keel is going. We can look at the overstuffing of the patellofemoral joint, the anterior condylar offsets, whether there is a notching or not. We can similarly look at the posterior condylar offsets. How much is a posterior joint overhang? Whether the femoral component should be in further flexion or extension, the position of the tibial keel, the slope of the tibia. Look at the overhang as well as the patellofemoral articulation. Once accurate planning has been done, we can then move to instrumentation, which will avoid intramedullary intervention. Simple, modular, reusable jig. All patient-specific instrumentation rely on the fact that there are 4 or 5 discrete points of contact on the bone in 3 different dimensions, which will help position or register the jig precisely. Here we are able to register this jig against the 2 posterior condyles, the 2 distal condyles, and the anterior cortex. So thus we have 5 points of contact. Based on our calculations, it's very easy to calculate the true AP distance for this individual, the amount of bushing required on the posterior side or on the distal side. Once this has been adjusted, all that needs to be done is to place it on the femur, lock it in such a manner that all 5 points of contact touch. Once the 2 posterior condyles, the 2 distal condyles, and the anterior cortex probe touch, it achieves one unique position, the position that you had planned preoperatively. Then it's very easy to mark for the distal cut and the 4-in-1 block. For the patient in the hospital, it saves time, less instrumentation, cost effective, highly accurate with no intramedullary violation. Yet another quote from Albert Einstein: I fear the day technology will surpass our human interaction. The world will have a generation of idiots. For total knees, where have we been going? We've been moving from computer navigation, PSI, robotics, effectively from either no planning or planning by a non-orthopedic surgeon to very precise execution at a huge cost, both in terms of time and money. Where should we be going? Very precise planning to fairly precise execution with a simple solution. With 3D augmented surgery, image capture is accurate. The landmark registration is done by the surgeon and hence is accurate for all 3 planes. It allows the surgeon to choose the best position for bony gap balancing. One can choose a personalized implant from a variety of off-the-shelf implants. Simple, modular, reusable instrumentation. Ideal post-COVID era digital technology. Thank you.
Dr. Manish, that was an amazing presentation. Thank you very much for that. Very slow, crisp, and very clear in articulation. And thank you. Any questions to Dr. Manish from Everett or from Alistair?
Manish, thank you. Fantastic. We all seem to be going in the same direction. It does, as you said at the end, the consequences of what we're doing, where I come from, you could never do this in South Africa because we just would not be able to bear the costs. And when Shri and I discussed this, we thought that somewhere like India or South Africa would do with a sort of a magical composite knee that would work mainly well on everybody. A quick fix knee would work well for everybody. How do you find that middle path between the beautiful stuff that you're doing with the potential, and you tell me if I'm wrong, with the potential that there's going to be a massive increase in the needs and the desires for knee replacements, particularly in a place like India?
I think that this probably will be the way forwards, in the sense that we'll be able to pick up the correct design of the knee. We'll be able to pick up the correct size of the knee and the ideal position for the patient. We've done about 700 so far. Studied 700 so far. And out of that, what we found is that even in the posterior slopes of the proximal tibia, there have been huge differences. Anything from a couple of degrees to 20-25 degrees of slope. In about 10% of patients, there has been a difference between the proximal slopes of medial condyle and the lateral condyle, which exceed 10 degrees. Now, all this, when you try and factor in your implant positioning, a 3D planning system really helps. Why did that first paper that I quoted caught my eye was that once we have been using a kind of off-the-shelf customization of implants, we have found that the need for soft tissue balancing has decreased significantly. The ease with which we are able to restore coronal alignment also has improved significantly.
Very convincing.
And that was kind of echoing our thoughts, and that's why as soon as I saw it, I picked it up.
Yeah, very, very convincing. And just listening to you, that is probably the way to go. And as we were joking before with Alistair, this sort of 3G project that can be well contained with the kind of the knowledge and the technical base that India has got to stay in-house. And you've got to be involved with these people to make it, easier and less financial burden on the country. And then you're home and dry, aren't you?
Amazing. Financially, I think it's a fraction of the cost that people are investing in the robots now. I think, a great concept. And I think that's the future, both for India, probably for the world as well. So amazing talk. Yeah.
Thank you.
Thank you.
Thanks, Dr. Manish. I think our next speaker is sadly stuck with a COVID patient in theater doing pelvic surgery. That's sort of, what I'll do is I'll skip his talk and I'll go to my presentation next. And if Mr. Acharya comes back from theater, then, he can join us. Otherwise, we'll reschedule his talk at a later date. I'll try to share my slide. So if you can unshare yours, Dr. Manish, then
I think I've unshared.
You've done it. Okay, thank you. So. It's quite a major topic, infected revision. So I can probably go all day with that. So probably I was hoping to rush because Mes would be around. Now I'll get more time to talk really. So, right. So I welcome everybody to this fascinating webinar. And, we heard some of the amazing futuristic talks. And This is my passion, infected revisions, and I'll briefly touch on where we are now in 2020 with respect to infected revisions, and also a little bit add a bit about the Indian experience and how we can improve things here. Experience relevant to this topic. I trained in UK in all aspects of orthopedics and trauma, and I have specialist interest in computer-assisted knee hip surgery and PSIs. I did a GMC recognized fellowship at Plymouth Teaching Hospitals for the same. I also have specialist interest in hip and knee revision surgery, and I trained under Dr. Everett Smith and Dr. Tony Ward, who are my mentors. And I thanks to them for where I am now. And after the Bristol Fellowship, I moved to Germany and I joined Prof. Gurka in Endo Clinic doing an infected revision fellowship. And as most of you know, Prof. Gurka is one of the authorities on single-stage septic revision surgery in the world. And they do unbelievable work. It's not just a hip and knee. Prof was showing single-stage revision of a disc replacement in the spine. So it was completely mind-blowing, really. And I should really thank Dr. Akka Zohar, who used to work with Prof. Gurka, along with the other two German surgeons, and for many of the slides that I'm going to show today. And Akos has now moved to Berlin. So he's become a head of infected revision unit in Berlin now, after moving away from Hamburg. As an introduction, I would like to say that in 1960s, Sir John Charnley reported around 10% infection after total hip replacements. And in 1979, he said that joint sepsis will be a major hurdle in our way in the future, and how true he was. Most authors now quote an infection rate of between 0.5 to 3%. The infection rate in centers of excellence is as low as 0.03%. And I'm really fortunate to have worked in 3 of those centers of excellence in UK, namely the Wrightington Hospital, Royal Orthopaedic Hospital, Birmingham, and Avon Orthopedic Center with Mr. Smith and Mr. Ward. And I also visited RNOH, another center of excellence last year, where Professor Alistair Hart works. Incidents and challenges. In US, around 4,000 hips get infected, needing revision every year. The cost of treatment is around $200 million per year. The diagnosis of periprosthetic joint infection, PJI, remains a mystery because there's no gold standard for diagnosis, and none of the available tests are 100% sensitive and specific. We don't have no accepted standard definition of PJI, and so various investigations are done. It adds to the cost, it adds to the delay in diagnosis, and hence it adds to delay in treatment. And the most important point is prosthetic joint infection is a killer. If you look at the 5-year mortality rate of that, it is around 34%, which is worse than breast cancer and testicular cancer. So we really, as arthroplasty surgeons, we really need to think, how to prevent this, because we don't want to give a surgery which has a worse mortality than breast cancer or testicular cancer. Prevention is better than cure. And these 2 slides are for the junior doctors. Ashok tells me around more than 800 doctors have joined online and watching. And these are 2 important slides for the junior surgeons in the group, in the delegate group. Prevention, appropriate patient selection is very, very important. Preoperative clinic is very important. You need to arrange if you don't have one, and where you do the workup of the patients. And we need to screen for the patients for any infection. During my UK time, MRSA screening was very, very common. And we had to do preoperative planning to reduce time of surgery. We heard a fantastic talk from Prof. Alistair Hart this morning about the 3D planning, another talk from Dr. Manish about planning. So in orthoplasty, there's a basic dictum. If you fail to prepare, you prepare to fail. An operation table is not a place to plan your surgery. An operation table is a place to execute your plan. So training of the staff and assistants to reduce operation time is very important. I still remember during my training in Royal Orthopaedic Hospital, Mr. Ronan Tracy had an assistant and one of the loudest scrubbers in the whole of theater. And even before Ronan would want the next instrument, he would put the instrument in his hand. So training of such staff is very important to reduce the operation time. Meticulous attention to aseptic precautions is very important. If you're doing urinary catheterization, you need to use antibiotic cover like gentamicin. And pre-prep in anesthetic room is very important. The timing of hair clipping is vital. It has to be done after the patient is positioned, and you should never shave, but if you just clip the hair, And then the technique of scrubbing, you need to have a proper technique, and particularly juniors, you need to watch that they're following all the principles of scrubbing. Positioning, draping of the patient is important. It's very important that you position the hip or the knee, because if the clamp put by your assistant is not secure, and if there is a tilt of the pelvis during your acetabular reaming, then you can get the whole operation wrong. And as Mr. Smith just mentioned, it is very, very important to get things right in the legal fashion. Even doing a normal hip is quite challenging because of so many factors involved. And then if we miss simple tricks like positioning the patient properly, then we can get into serious legal suit, particularly in our country. Then how else to prevent? Light handles, yes, if they're with blood, more than 2 hours, they can colonize. So you need to change the light handles or use a condom catheter, which can be changed around the light handles every 2 hours. Suction tube, a great study we did in Wrightington. If you keep the suction tube on for all the time, and if you culture the suction tube tapes, they grow bacteria. So you clamp them and then use it only when you need to really, the blood is there, then you use unclamp the suction tube. Surgeon drape, we all know about the wet bacterial strike through. They should be non-permeable. And here, they should be well covered. And mask, we don't need to talk about mask in the COVID times now. You need to cover now. Even the anesthetists have to wear mask properly. And IO-band, yeah, very useful, where the skin incision happens. And preoperative antibiotic timing just before surgery or before you blow up the tourniquet. And this is important that the antibiotic should be chosen based on the antiviagram of that particular area done by the microbiologist, because we know what bacteria are prevalent and what is the antibiotic to give. Double glowing is very important. Tranexamic acid is a game changer. It is cheap and it's reduced bleeding following surgery and reduce the need for blood transfusion. We know that more the blood transfusion, more chance of infection. Clean air theater is very important. There was a controversial paper from New Zealand that laminar flow was not needed, but I think generally it's accepted world over that laminar flow is important. Space suits are very important to reduce infection. And in this COVID times, my center, along with the IIT engineer from Chennai, we have devised a spacesuit which is almost 99% accurate for COVID, and it's also very cheap. So it's something that we want to bring it in the market, both in India and abroad. So theater traffic is very important. We need to control the theater traffic, and glove change, before implantation of the final implant is very, very important. I think I changed my gloves quite a lot during surgery, and around 8 to 10, 12 pairs I changed, and I think the glove company makes a lot of money because of my practice, and this is to prevent infection basically. Surgical technique is important. It should be meticulous, and tissue handling should be minimal. Pulse lavage should be used. We did an audit in Arrow Park Hospital where 3 liters of pulsatile wash before implantation, 3 liters after seemed to reduce infection. Antiseptic irrigation of the wound or the implant is important with betadine or chlorhexidine. Hydrogen peroxide has gone out of favor now because there was a death in the UK recently following use of hydrogen peroxide. And the implantation technique is very, very important. The final hip, you had to change the glove, and you should ensure that you don't touch the skin. The implant doesn't touch the skin while it goes inside the bone. Post-operative antibiotic care is very important, and when you do the change of dressing is important. It's my practice that I don't change the dressing for 12 to 14 days post-surgery. Whenever they come for clip removal, it's changed. Unless it oozes a lot, then it's changed just before discharge. Drain versus no drain. I have not used drain in my hips and knees for the last 10 years now. I don't even use a tourniquet for the knee, and the patients are ecstatic and no complaints really. Post-operative hyperthermia versus hypothermia. And we normally think that hyperthermia, it is the post-op hypothermia which actually causes more infections following surgery. Now you've done the total joint, hip and knee, and it's infected. What now? And what to do? This is for the seniors. And let us look at the problem. We know the number of primary total hip replacements are on the rise. The number of revisions are on the rise. Number of primary total knee replacements are on the rise, and the number of revision knees are also on the rise. So infection following primary near hip replacement is about 0.3 to 3%, but in revision it doubles between 3 to 7%. Every painful joint, hip or knee, is infected unless proved otherwise. We need to really know, do we have a concept? Who is my enemy? And do I have a concept to beat my enemy? This is very important. And the enemy in infection is no other than the biofilm, or what we call as glycocalyx, where the bacteria can hide and the antibiotic resistance increases 500-fold. And there's no physical or chemical method to remove the biofilm. We all know about this classification of infection from Coventry and Fitzgerald. Type 1 infection is immediate post-op infection. The wound becomes woozy. It's acute infection within 4 weeks of time. You need to debride, change the liner on the head. 50 to 60% success rate with this. Type 2 infection is a delayed infection. It happens after 4 weeks when the organism had time to form biofilm, and hence, the implant has to be removed. Either a 2-stage or a single-stage revision needs to be done. Depending on the organism, section comes back positive at the time of revision, and the culture also comes back positive. So you can only treat this with suppressive antibiotic therapy. So how do we deal with periprosthetic infection? What are the useful things? First is patient history, clinical signs and symptoms, x-rays, and investigations. Patient history is very important, particularly pain, night sweats, fever, and if there is any previous history of surgery due to infection. If there is none, then the chance of infection, as we mentioned, is less than 3%. But if there are 3 surgeries because of previous infection, the chance of infection increases to 15%. Appearance of the wound. In a third of patient, the wound has no pathological findings. In a third, there is induration and redness. In a third, there is fistula. And in 2%, there are wound defects. X-rays, what do we see? We see osteolysis, radiolucencies, and ossification. In septic loosening, if you look at the joints, in 50%, both the components are well fixed. In 1/3 of cases, one component is loose, and in 17% of the patients, both the components are loose. So let us come to the other investigation, and the most important thing is a joint aspiration. This is how it is done in the theater. These are the golden rules of joint aspiration. It should be done in an operating condition, that is an operating room. All the antibiotics should be stopped 2 weeks before aspiration. The culture should be done at least for 14 days. This is very, very important because in India, most of the labs culture for only 7 days. And I had several debates with a lot of top pathologists in Delhi, Hyderabad, everywhere, because my samples go to all these places, and it has to be for 2 weeks. No local anesthesia has to be used. No irrigations have to be used. And it is very important to take the sample and subject it to the synovial fluid analysis. And if there is more than 3,000 white cells per microliter in the chronic infection, or more than 10,000 in acute, and if there's significant neutrophilia, more than 70% in chronic infection, or more than 90% in acute infection, then it's definitely infected. Microbiology, what do we exactly see? The most common bacteria is the Staphylococcus epidermidis, called the coagulase negative staphylococcus. Second is by Staph aureus. Gram-negative bacteria like E. coli are on the rise. MRSA and MRSA, that is methicillin-resistant Staphylococcus epidermidis, have increased to around 30% now compared to around 10% 5 years ago. CNS and Staph aureus form biofilm or glycocalyx, and hence, they have to be, there's no way to give antibiotic because antibiotic resistance increases 500-fold. So there's no physical or chemical method to remove this. That means once biofilm means you have to remove the implant. Let's look at the accuracy of joint aspiration. It's more than 90%. This is the most important slide. This is microbiology. You can see here that if you just incubate for 1 week, happens in many labs in India, you only pick up 70% of the bugs. But if you incubate for 2 weeks, then you can pick up 100% of the bugs. This is another important slide. If you incubate for the second week, which are the bugs you're going to pick up? These are like Propionibacterium species and Peptostreptococci. So if it's only 1 week, only aerobic culture is done, then these bacteria are missed, and then it comes as aseptic loosening and will be full. So let's look at biopsy. So biopsy is probably more accurate than aspiration. Its accuracy is around 98%. So the key points in investigation are, if ESR and CRP are normal, only 4% chance of infection. Nuclear medicine is still non-clear medicine. So still no role, except if it is negative after 2 years, you can tell the patient that there's no infection, you not come back to me again. If the ESR is more than 30 in a chronic infection, CRP is more than 10 in a chronic state or 100 in acute state, synovial WBC count is more, as I mentioned before, with polymorphic leukocytosis, it indicates infection. Leukocyte esterase test is a cheap test, is more than 2 plus indicates infection. Synovial is flow test, is a good test, but it is expensive. PCR is useful for bacterial DNA. Culture swabs, which we traditionally take, has got high false negative and high false positive rates, and hence it has to be, this practice has to be binned. X-rays will show rapidly progressing radiolucent lines, mantle fracture, cup stem migration, protrusion, fracture, and implant breakage. So what are the treatment principles or algorithm? We have to take a history, examine the patient, check at bloods, plus X-ray, and if there's a major criteria like a sinus tract communicating with the implant and pouring pus, you have to revise. If there's no major criteria, then you have to investigate, aspirate, culture, and if more than 6 minor criteria are positive, you have to revise. Sometimes we get dry tap. What do you do there? So you get a dry tap, and some ESR CRP is high, then you do a second aspiration around 3 weeks later. You send for acid phosphacylate and fungal culture. If they come back positive and 3 minor criteria are positive, you go for revision. So because there's so much of diagnostic confusion, Prof. Javed Parfezi from US and Prof. Thorsten Gerker from Germany, they came to this international consensus meeting first time in 2013 at Rothman Institute, Philadelphia. And the last consensus meeting happened in 2018, where all the top surgeons from the world, go and discuss through a Delphi meeting and vote the way forward. And they came out with definition that a major criteria is a sinus tract communicating with the skin and the implant pouring pus. There are several minor criteria. The 2018 consensus shows very clearly what are the cutoff marks here. You can look at the CRP for acute stage, chronic stage, and gives points like 2. ESR also for chronic stage 1, and positive alpha defensin gets 3, and single positive culture 2, and positive histology 3. So like this, you keep adding it and you get a score. If the score is more than 6, it's infected, you revise. If the score is less than 3, it's not infected, don't revise. What if it's between like 3 or 4, or 5? So then you have to do further tests like molecular biologic methods to find out if it's infected. This is a very barn door case, very easy. You see, you score 10 points, ESR CRP is high, culture is positive, infected, go for revision. But there can be confusions. In this case, it's 3. CRP is normal, ESR is elevated, culture is negative. So it could be rheumatoid. So one needs to know what other differential diagnosis is possible. MDT meeting is multidisciplinary team meeting. It's very important. It should be done on a weekly basis. All relevant findings should be presented and discussed here. The radiology findings should be also looked into. The key questions in the MDT are diagnosis of PJ. Is this infected? More diagnostic tests needed. What is the type of revision we have to do? Single stage or 2 stage? What is the antibiotic we have to use depending on antibiogram? And what is the type of cement? Do we need to order a special cement like Copal? This is the algorithm now, modern algorithm to treat the infection. So if it's infected and the implant is stable, less than 4 weeks, you go for DARE, which is debridement and retain the implant. And if you find that in this case, within 4 weeks, the implant is loose, we can go for a single stage revision. Suppose if the organism is not mildly virulent, but very highly virulent, or if the organism is not identified, or if there is a soft tissue problem, then you have to go for a 2-stage revision. Suppose if the patient is unfit, then you can go for long-term suppressive antibiotic. Last resort, if nothing can be done, you can go for either hip disarticulation or arthrodesis or abony amputation. This is how they treat in endoclinic, either with single-stage revision, option 1, or 2-stage revision, antibiotic suppression, fistula persistence, resection orthoplasty, or debridement and retention of prosthesis, which is basically DARE procedure. So what are the indications for DARE procedure? It's an acute hematogenous infection, less than 4 weeks old, intact soft tissues, solid implants, no bone loss, and exchange of modular implants is possible. So DARE, soft tissue debridement, you can do suction irrigation, antibiotics for 3 months. Success rate is between 50 to 60%. If it's more than 4 weeks, you have to go for revision. One-stage revision, endoclinic specialized in one-stage revision. They've been doing it not just now, but for 38 years. This came from Professor Buchholz, who said, mentioned the concept of local antimicrobial delivery by loading PMMA with different antibiotics. He said that antibiotics protect the surface of the newly implanted processes from recolonization by bacteria remaining at the site. This is not a new concept. It is as old as Hippocrates, around 480. He said if there is pus, you have to evacuate the pus. And here on the right-hand side, Prof. Gurkha is doing a radical operation. The key is hit them hard, be radical. And on the left-hand side, you see, single-stage infected revision where the amount of, the stuff removed during surgery is unbelievable. Excision of the scar is a must. And lavage with Lavasat is what they use in endoclinic. But here in India, we use betadine and chlorhexidine. Now, hydrogen peroxide should not be used. And this is how it looks. You can just see it looks like tumor surgery. Literally, this is a radical debridement, and this is how a single-stage revision succeeds. This is the most important person and part of the team, the microbiologist. Lars is a microbiologist in endoclinic, but here, I'll tell my own story. I've got 20 microbiologists in Bangalore with whom I'm in touch. I'm very, I persist and keep on chasing the results. 15 of them don't pick my call. So only 5 of them pick, and then 2 of them are very senior professors, are completely passionate about, microbiology and the bugs, and, they're part of my MDT team. This is a single-stage revision of a knee, and you can see that this is a hinged implant because endoclinic believes that these bacteria can hide in the collateral ligament. So they basically remove the collaterals. Once collaterals are removed, you are forced to do a cemented hinge. This is pictures of a single-stage revision of the hip and the knee, all cemented implants. There is no role for bone graft. There's no role for uncemented implants, and there's no role for cement beads in single-stage revision. Although, increasingly now people are started using trabecular metal in single-stage revisions, and also some people are using uncemented implant. Post-operative care, daily wound control, systemic antibiotics to be given for 2 to 3 weeks, rounds with surgeon and microbiologist twice a week, control of blood parameters, CRP, liver function, and kidney function tests twice per week, and daily physiotherapy rounds. What are the indications for two-stage revision? Preoperatively, you can't find a pathogen, bug not identified, no possibility of local antibiotic application due to either allergy to the antibiotic, extensive infection without any possibility for radical debridement because the infective focus is very close to important neurovascular structures where you can't be radical. So in endoclinic, success rate is around 88%. The surgical time is around 175 minutes, the average time, and sometimes the length of stay can be as high as 33 days. These are the papers comparing single versus two-stage. You can see that the success rate of two-stage revision is between 90 and 95%. And you can look at the single stage, that's also coming close to 90-92%. So what are the advantages of single stage revision? Less stress for the patient, less risk of complication, it is less expensive, better surgical conditions, better functional results. Definitely, all the recent papers show better functional results, more or less same results for control of infection. Minor disadvantage, slightly higher rate of aseptic loosening of around 3.8% at 6 years. So what do they do in endoclinic now? 84% get a single stage exchange, 9% get a two-stage exchange, 4% get a DARE, 1% each get an antibiotic suppression, fistula persistence, or a resection orthoplasty. So what are the difference between the two things? Both have implant removal, single and two-stage. Both have a debridement, and there is a period interval without processes in a two-stage exchange, and there is a debridement further in a two-stage exchange, and both of them get an implant done finally. As Prof. Mike Freeman from London used to say, I do a two-stage in one session. What is the future of prosthetic joint infection treatment? Newer diagnostic tools have come like PCR spectroscopy, molecular markers like alpha defensins already being used. Patch test is coming for infection called microbead detector test. New drugs are coming like anti-MRSA drugs, and we got a new beta-lactam antibiotic. We got a new rifampicin also on coming, And one of the recent things is that the bacteria can hide within the cell, intracellular, like COVID, and it's very difficult to reach. And now in the Western world, it's found that rifampicin is the drug of choice to kill these bacteria. But in India, unfortunately, we have rifampicin resistant tuberculosis. So this is going to be a major challenge. And I'll present this more in my other slides. There is an anti-staphylococcal vaccine being prepared, and anti-biofilm agents like benzimidazole or P are being tried. Silver and vancomycin coated implants already being used in the trauma. So the take-home points are prosthetic joint infection is a challenging condition. We'll test the experienced surgeon. You need to be not only a good arthroplasty surgeon, but also a good trauma surgeon to deal with it. Adherence to the revision arthroplasty principles is important. It needs passion, teamwork, patience, resilience, and is definitely not for the novice. Like they say in the accident and emergency in the UK, if in doubt, refer to a trained specialist. So the take-home message is be radical. Just a few slides on where are we in 2020, some updated literature. We know indication for single-stage revision, we have just covered it. We know that single-stage revision is a panacea for around 85-90% of the patients, and remaining 10-15% need a two-stage revision. What are the key steps of a single-stage revision? This is important. Excise the old scar and infected subcutaneous tissue. Radical synovectomy, including dorsal capsule in the knee. Remove all foreign material. Radical and aggressive debridement of the bone. Local antiseptic pulsatile jet lavage. You redrape, rescrub, new instruments, and then direct reimplantation with antibiotic bone cement. This is one example where an uncemented process is done, it's infected. So ETO has been done, and then the cemented process has been put with a proper antibiotic loaded cement. What are the benefits of one stage? Debridement is more radical, less mortality and morbidity. Antibiotic treatment is shorter if you use a cemented implant. Lower cost, in 90% only one surgery is needed. It's as effective as two-stage procedure. No impairment with spacer and high acceptance by the patients. It's a very attractive option for the patient and the surgeon. So what are the indications of two-stage? If there's a culture negative infection, difficult to treat bugs like E. coli, local antibiotic therapy not possible, radical debridement not possible, or if the source of infection is extra-articular, then you have to do a two-stage procedure. When to reimplant in a two-stage? A very important question often asked. So this can be done when the clinical signs of infection have calmed down. So that is the knee or the hip has calmed down, fewer pain or less. Recovery of the soft tissues is complete, and then you can go ahead. CRP and ESR should be down back to baseline. No need for repeat aspiration or no need for a bone scan. Alpha defensin is useless. Intraoperative specimen can be done for frozen section. I use it quite routinely here in Bangalore. Regular time to put the process is around 6 weeks, but it can range from 2 weeks to 12 weeks. This is a very important slide, how long you need to give the antibiotic. If it's a single stage exchange, if you're using a cemented implant, you can just give antibiotic for 2 weeks. But if you're using a cementless, you need to give for 6 weeks. In two stage, if reimplantation with cement, you can give for 2 weeks. Again, without cementless, you have to give for 6 weeks. In there, you have to give for 3 months time. If you are going for antibiotic suppression, you can give between 3 to 24 months. This is one of the options when everything has failed, a fusion nail for the knee. So in summary, diagnosis of prosthetic joint infection is challenging. Several diagnostic modalities are used. Multidisciplinary approach is very, very important. DARE can be done in acute infection. Two-stage revision is the gold standard. Single-stage revision for selected cases. Tertiary referral centers for PJA treatment is very, very important. I'll just briefly take you through a few of my Indian experience, what lessons I've learned really. The first is a 66-year-old lady. She was a 120 kilogram diabetic. She was operated by top two, the orthoplasty surgeon for my state, Karnataka. Unfortunately, the knee got infected. Surgeon tried 5 more surgeries, to eradicate this, and that was not possible. Finally, decided on excision orthoplasty, and she was without a knee joint. And because of her obesity, she was bedridden for nearly 2 years. Our daughter came to me and said, Dr. Srikanth, can you really help? I can't manage her. And I said, this is my training, what I got from Prof. Garka. and Mr. Everett Smith at Orthopaedic Center. So I'm happy to take her on. And I planned this, and this was the X-ray on the left. A stemmed implant was used for a primary arthroplasty, and this is how she came to me on the right side. The issues that I faced were morbid obesity. She was diabetic, and one of the surgeries in the past, the quadriceps had ruptured. This was repaired. So there are 5 failed surgeries in the past. There were multiple scars. You can see that I have marked the scar with the blue ink there. And in the last surgery, the surgeon was not able to close the wound. So he had asked his plastic surgical colleague to come and help, and he had put a gastrocnemius flap. So I was aware that, if I am going further, I will be left with only one more head of gastrocnemius. And the patient needed a bariatric table and a bold anesthetist to take her on. So I aspirated the knee, it grew E. coli. So I knew one single stage was not possible. It was a 2-stage revision. And I created an antibiotic spacer with a proper antibiogram. And it was on the table made spacer, not a custom made spacer. And we gave antibiotic, and the ESR and CRP came down to normal in around 8 weeks' time. The issue in the second stage was the hospital setup. We needed a very good ICU backup. So we had to use a hospital, what's called as a corporate hospital in India. The teamwork was a combined plastic and ortho teamwork. I had to get clearances from the physician, the nephrologist, cardiologist. There were some vascular issues. I had to get a senior vascular surgeon on board and get an opinion of the senior anesthetist as well. So the challenges during surgery were the type of anesthesia. It was a prolonged surgery lasting 4 to 5 hours. There were massive fluid shift. So the patient was shifted to ICU and promptly extubated after 24 hours. There was issue with quality of the quadriceps, despite quadriceps snip, so that was dealt with. And after many more challenges, a RHK was done with a full tibial augment on the tibial side. And this is her, able to walk nearly 2.5 years after her last surgery. And this is what, as a surgeon, gives you happiness, able to make people walk again when they are not being able to walk for 2 years of bedridden state and the family is really struggling. Second case is an osteoporotic challenge. And this was, again, a 50-year-old lady, and she had, again, not walked for 2 years. And I still remember she was literally carried by her son. She was a petite woman, and she was literally carried by her son in the hands, like that. And he came into my center and made her lie down on the examination couch. And one of the senior professors of orthopedics in Bangalore, who's been a professor to my teachers, had mentioned to this patient and relative that God help you. And one of the surgeons had put a needle and tried to aspirate, and aspirate was negative. She basically came with what was a pathological dislocation, 90 degrees FFT. I organized the MRI scan. It showed complete destruction of the joint, ACL, PCL. Pus was there right from the trochanter up to the ankle. So I planned for a 2-stage revision. In stage 1, I opened up did open reduction, reduced the dislocation, and did a radical debridement, and put a cement spacer with antibiotic. And I literally sent for every investigation, I mentioned. And it went to different parts of India as well. And to my surprise, although there was frank pus, all the investigation came back negative. Fortunately, I always sent the samples to the histopathologist as well. And Dr. Prasad was my classmate. I didn't realize that, he was my classmate in high school, and he's now a prominent histopathologist in Bangalore. He called me next day, and he said, Shrikant, this is a classic case-eating granuloma, tuberculosis. So he really saved the day because I had no way to go about what was going on with this lady really. And the second stage was planned. I told the family, shall I put a hinge knee? Is that okay? They said, sir, we don't have money. We can't afford this hinge knee. And if it gets infected again, we are completely gone. So I had to plan for a knee fusion. And I checked, the Striker T2 nails, and they were as expensive as the RHK. So there was no option to use it. So I scouted around and I called many companies, and one of the company in Ahmedabad, where Dr. Manish comes from, they were kind enough. They said they sort of customized a kind of a T2 nail, a long nail, for fusion. And I sent them the measurements, and they made it, and they sent it in a few weeks' time. And I put this nail and, put the knee in the functional position for orthosis, locked it proximally and distally. So distally, there was hardly any bone. It was completely air shot, very osteoporotic. So used, POP to maintain the position. And I gave ATT for 6 to 9 months, and the knee fused in around 6 months' time, and patient was able to full weight bear. But unfortunately, after around a year's time, she developed respiratory infection and she passed on. So the Indian practice, what are the changes I've been seeing? What is needed is, the patient referral system needs to be straightened up really. Because, for example, if there's a patient in Macclesfield, Alistair and Everett would understand this, and they get a polytrauma, and instead of going to Manchester Hospital, to somebody like Tony Clayson, if they end up in Harley Street, all the way in London, it may be good for Harley Street, but it's not good for the patient. And Alistair written in many websites that it's very patient-centric treatment, and that's very, very important. Putting patient at the center of the care, and this thing has to change. The second is, the multidisciplinary team. I've established one infection and need of the hour. Even in geriatric orthopedics, we're seeing here, professors in AIMS are trying to get a multidisciplinary team for facility fractures and get, the orthogeriatricians who are a rare commodity in India. And, another important thing is training of junior doctors, particularly on evidence-based medicine. And this meet is an effort in the direction, to push evidence-based medicine in India. And antibiotic etiquette is very, very important, because 64% of antibiotics sold in India are unapproved. And there's a study, I think, in Lancet in 2018 to this effect. And I'll just show you one real patient of mine, what happened. If you just see, this is an antibiogram of a patient. She grew Acetobacter baumannii, and you can just see the antibiogram, resistant to every antibiotic available in India. And it's not surprising to say that this lady passed away. She passed on. So, it's very, very important that the government has to come up with a regulation on the sale of antibiotic, and the over-the-counter, delivery of antibiotics should be banned in India. It should be only prescription-based. And this is how we can fight antibiotic resistance in India. So I already mentioned that, the intracellular bugs are on the rise now, and rifampicin is the only thing we used everywhere in the world. But in India, we have rifampicin-resistant tuberculosis. And also, financial support is needed for these patients, because they had multiple surgeries and often they're broke by the time they come to me. And we need to tell the implant companies, major ones like a DPO or Stryker, that they need to have some sort of an insurance system. If the primary implant costs X, they can charge 10-20% on top of that for the insurance. Suppose the implant breaks, or there is dislocation, or there's infection, this extra cost can pay for the next surgery and for the implants. And this is very, very important for a developing country like India. I was in a meeting with Professor Ross Crawford from Australia just this Sunday, a few days ago, and I met him in India. He's a very pleasant man. Last Sunday, he was lashing out in the webinar, and he said, oh, no one in India knows how to put a cemented hip, and what to say of infected divisions. And he also made a comment that, practice here should be driven by evidence, but not by greed. I really didn't understand what he was saying. Prof. Crawford is very common to India. Last 2-3 decades he's visiting. I'm a baby here, only 6-7 years. So next time I meet him, I'll ask him what he meant by that. So my take-home message is, infected division surgery is a complex area of work, can take from 2 to 5 hours, and one can run out of steam if not trained in these difficult procedures. Training is a must to perform these complex work to an acceptable standards. In advanced countries, all infected divisions are referred by surgeons for a tertiary referral centers. And the key thing is, prosthetic joint infection is a killer, and its outcome is worse than breast and testicular cancer. Your best chance is prevention of infection with careful case selection for the primary cases, meticulous pre, intra, and post-op care during the primary surgery. And like I mentioned, so this surgery not to be performed by the novice. Attending a Sunday webinar, this again happened because Prof. Crawford was talking about impaction bone grafting in femur. He said, now all of you, don't start doing impaction bone grafting just because you listen to a webinar, because you ask the companies to train you how to use the phantoms properly. So this is important because in India, we have a very hostile judicial system where there's no upper limit on capping for compensation for patients in the litigation. It's a bit like American system. But in UK, I think there's a capping. And even in the ASR cases, I don't think a huge amount of payout has happened, unlike in the US. So when things go wrong in India, we'll be roasted in the courts of law and also professionally jousted, which is very unique to India. So when in doubt, refer to an appropriate trained specialist. So I thank you very much for this patient listening. And for those of you in India who are not into infantry division, I seek your support to serve these patients. So I thank you very much. I think I'll stop here because there are a few more cases, but that's not important. It looks like Dr. Mehul Acharya is sort of still stuck in theater doing a difficult, pelvic surgery in a COVID patient. So I don't know how long he will take actually. If there are any questions, we will just have a chat. And, if there's nothing, then we will sort of conclude. There's no message from Mess. So probably he's still stuck in theater. So I think it was a great talk. So probably I'll reschedule this talk for the next time. Any question, Dr. Manish, ever?
The way you investigate it and the way you treat it, because it's a really huge talk. One thing does strike me, and I'm sure Manish has picked up on there. There's so many points, Shri, on an excellent talk. But the one thing does sort of strike me. We go through all of these things, and then when we do all these tests and we get to a state where we've got what we think is a high suspicion or high index of suspicion of an infection, and then we go to theatre, and then, as you said, a proportion of the specimens that are taken don't find a bacteria, or bacteria is not isolated. The question that I have really in terms of fundamental surgery is, if you get in there and you take your multiple specimens from multiple sites and you do an excellent or more than adequate debridement, shouldn't we be taking specimens at the end of the procedure before we leave to confirm that we've actually got to that point? And why isn't it part of an analysis of an infected joint?
I think that's an excellent question, Everett. I think you're right. We should probably be taking some specimens as well. In Plymouth, where I trained, fortunately, we had a good unit doing the frozen section. And it was my job as a fellow to call up the histopathology department, send the frozen section, and then we'd get the results. They had the cutoff above 10, below 10, and then we would go ahead. And sometimes we are just caught out and we think it's aseptic loosening, but it's actually infection. And I think the only way ahead in these cases is a suppressive antibiotic therapy, really, because we already put the implant and there's nothing can be done, really.
Brilliant. That's a fantastic talk and a fantastic Zoom webinar. And again, wonderful being in touch with my Indian friends. Even better.
Thanks, Everett. Thank you so much. I think it's been a fantastic success.
And thanks to Manish as well. And thanks to Alistair.
Yeah, Ashok tells me there are more than 800 joining. I just checked the YouTube, 20 joined.
He's the hidden man.
Yeah, Ashok is amazing. I think, he should really, the amount of webinars he has done in the last 6 months, he should really.
He sneaks in like the ghost. I told him he's like the ghost.
Medal, really.
Thanks to you all. I have to go and do a clinic at about 2 o'clock, so I'm going to charge off.
Yeah, thanks, Everett. Thank you very much. Thanks
to all of you.
Thanks to Prof. Hart. Thank you very much. Bye-bye from India. Bye-bye.
Bye-bye.